Hello, everyone. My name's Tommy, and I'm here with Bite Sized ID today to talk to you about assessing penicillin allergies in the community setting. So, I'll start with some history and incidents about penicillin allergies and how they came about. So, of all the medication allergies reported out there, about 10% of them are reported to be of penicillin based antibiotics, and that includes stuff like penicillin, amoxicillin, with or without clavulanic acid, dicloxacillin, things of that sort. Of that group of allergies, only about 10% of them actually turn out to be true allergies, though. The other 90% of them, if they were given a penicillin allergy skin test, would actually turn out to be negative, and they would have a tolerance to future exposure to penicillins. And that's for several reasons. Mostly because a lot of the allergies that they list are not truly allergies for various reasons that we'll talk about later. And then people also tend to outgrow these allergies. So 50% of people will typically outgrow a penicillin allergy in 5 years, and 80% of them will be able to outgrow it in 10 years. A patient's penicillin allergy status can have a very important role in their healthcare as well as our larger healthcare systems. When we aren't able to use a penicillin antibiotic because a patient has an allergy, it's been shown to have several negative effects. It's been shown to have an increased outpatient mortality as well as a longer hospital stay when we can't use our drugs of choice when they're penicillin based due to allergies. Not being able to use them also can lead to inappropriate antibiotic prescribing, with excessive broad agents having to be used to overcome patients' allergies instead. This in turn can lead to development of antimicrobial resistance, and then those can turn into infections that then need to be treated as well. Using some of our non penicillin based antibiotics also leads to excess healthcare costs because a lot of them can be more expensive than penicillin based ones. Using non penicillin based antibiotics can also lead to increased surgical site infections since we may be using suboptimal second line therapy for them for prophylaxis. When you have a patient who states that they have a penicillin allergy, there are several things that you should do to assess to make sure if that allergy is a true allergy or to decide if it is not. And the most important thing to start with is an accurate allergy history from the patient. This includes several different questions that you can ask them, such as what happens when you take penicillin? Did you have a anaphylaxis or IgE mediated reaction per se, or did they just have some kind of non-allergy reaction? How many years ago was the reaction can be important? Did it occur in their childhood, or did it occur really very recently in adulthood? What did you do to manage the reaction? Did the patient just stop taking the medication, or did they require use of EpiPen, Benadryl, and a trip to the emergency department? What was the reason they were taking the antibiotic in the first place? That can help rule out sometimes other effects of other medications. And then have you tolerated other penicillins or cephalosporins since that reaction? A lot of times a patient may say they're allergic to penicillin, but then they often may be able to take augmentin, which is amoxicillin with clavulanic acid, which may indicate that the patient is no longer allergic. When asking these questions for a patient, it's also important to keep them open-ended. Make sure that you give the patient an opportunity to respond with their own answers before you prompt them. When we collect our allergy history for the patient, we're often trying to determine if it is a true allergy or if they may just have an intolerance. A true allergy to a medication is typically IgE mediated with an immediate type reaction, while intolerance are often expected side effects from medications and not immune system mediated. Some allergies may not be immediate, they may be delayed, and these ones are typically more IgG mediated and should be considered serious as well, while intolerances should be considered as not quite as serious and would not prevent the use of a medication while an allergy would. Some common intolerances reported by patients for medications include diarrhea, nausea and vomiting, headache, as well as family histories. Common allergies that should be considered true allergies are things such as anaphylaxis, angioedema, hypotension, hives, wheezing, and then some of our more IgG mediated ones such as SJS, TEN, and DRESS. Another tool that we have at our disposal, besides an accurate allergy history to determine if a patient may have a true allergy or not, is called a PENFAST score. This is a clinical decision tool with a high negative predictive value used to assess the need for skin testing for patients who may have true allergies. It consists of several different components. We look for a patient who may have 5 years or less since a reaction. A negative answer would score 0 points, while a positive answer would score 2 points. We ask what kind of reaction they had. If it was anaphylaxis, angioedema, or a severe cutaneous event, they would score 2 points. And then if the treatment was required for the reaction, such as an EpiPen or the need for immediate Benadryl or trip to the ER, that would score them 2 points as well. You then total a patient's score, and a score of 2 or less had a near 100% negative predictive value at identifying patients who could receive direct oral challenges. Scores greater than 2 do indicate the need for possible skin testing for assessment and may indicate a higher chance of having a true penicillin allergy. One study that helped validate the PENFAST score was the PALACE trial. It included 377 adults with penicillin allergies with PENFAST scores of less than or equal to 2. It excluded those with anaphylaxis, self-reported allergies deemed to be intolerances such as nausea, vomiting, and diarrhea, as well as those with severe delayed non-IgE reactions. It worked by randomizing patients to either direct oral penicillin challenges or intradermal testing followed by an oral penicillin challenging. The results showed that only one patient in each group had a reaction, and the risk difference was found to be very small at 0.0084. This suggested that the PENFAST score could be utilized to determine if patients were at a high risk for a reaction and needed intradermal testing, or could go straight to an oral challenge because they were low risk for having a true penicillin allergy. Penicillin cross-reactivity with cephalosporins and other beta-lactams is something that also comes up quite a lot. Overall cross-reactivity of penicillin allergies with cephalosporins is low. It's found to be about 1% when using first-generation cephalosporins with similar side chains, and even less than that at less than 1% when using third or fourth-generation cephalosporins with unsimilar side chains. The risk does seem to be the highest with penicillin and cefadroxil, though. Overall cross-reactivity with penicillin allergies and carbapenems is less than 1% and found to be very low as well. We do recommend the use of side chain comparator tools to help you assess this risk, such as the one shown on the next slide. Here is an example of a penicillin and cephalosporin, as well as other beta-lactam cross-reactivity chart. You can see in the top left corner, we have our penicillin type antibiotics such as ampicillin and amoxicillin. And you can see going to the right, we have various different cephalosporins. So our ampicillin, amoxicillin, and penicillin may have reactions with some of those other penicillins, of course, as well as cross-reactivity with some of our first-generation cephalosporins, such as cephalexin and cefadroxil. Outside of the first-generation cephalosporins, there appears to be very low risk of cross-reactivity between agents, so it should not prevent the use of a cephalosporin in a patient who has a penicillin type allergy. Penicillin allergy skin testing may also be available to help rule out if a patient has a true allergy or not. This utilizes penicillin antigen injected intradermally to assess for an IgE-related immune response. This can be followed by an oral challenge as well to ensure tolerability from that standpoint. Outpatient penicillin allergy evaluations are available by referral to Carilion Allergy and Immunology Clinic. However, availability is quite limited, so should be reserved at this time for patients who may benefit from the use of a penicillin type antibiotic due to certain diseases. Overall, when you're assessing a patient for a penicillin allergy, always obtain an accurate allergy history from them to make sure you have all the information available to make an accurate decision. Keep in mind that a drug intolerance does not always equal a drug allergy, so things like nausea, vomiting, and diarrhea may be quite common reactions from an antibiotic, but it doesn't mean that they have an allergy and should not prevent the use of it. Be sure to utilize the PENFAST score This can help you quickly screen for those who might have a high risk of having a true penicillin allergy. And remember that penicillin allergies do not cross react with all beta lactam type antibiotics, so that should not prevent you from using things like cephalosporins or carbapenems as well. Thank you for listening to this bite sized ID presentation on assessing penicillin allergies in the community setting. If you haven't already, use this QR code as well as instructions to download our AMS app yet on your phone. This will give you access to other great pieces of information on stewardship initiatives, guidelines, as well as other bite sized ID presentations. Thank you.